Hello, everyone. My name is Hamad Ektiari. I'm delighted to be here today. It's 5:55 a.m. here in Minneapolis, early in the morning on Sunday, and I can imagine it should be afternoon time in India. And I mean, different time. I mean, we have people from different time zones. I'm really excited to share some of the kind of recent advances about neuromodulation and addiction with you today. So let me kind of share my screen and see what we have here. Okay, today we are going to talk about brain stimulation or neuromodulation for addiction medicine and psychiatry. I do not have any conflict of interest. I have a group of colleagues and collaborators here in the University of Minnesota and at the Institute for Brain Research. I'm really thankful of all of them because, I mean, it was not possible to present the things that I'm going to talk about today without their support. So before starting the actual scientific part of the talk, if I can provide you with a really nice brownie like this, and I ask you whether you like to eat it or not, and whether it makes you crave having a piece of chocolate. And if I ask you to provide a number from 0 to 100, and 100 is the kind of the really strong craving that you have for chocolate, can you just provide a number in the chat space and give us a sense about how much you like to have this piece of brownie? 100, 48, 100, okay. 50, 0, 100. Okay, good. So people provide different numbers for the level of craving that they have when they see something like this. And this is the case for people who are using substances. When we expose them to drug-related cues, and we call it cue-induced craving, they can have a level of craving in terms of they really like to use substances. And over the time, we try to develop different drug cues that would provide people with the contextual information about drug cues, and that we show that these databases of drug cues could get them to a level of craving. And we have published those Q databases, so you can easily have access to those Q databases that we developed. And what we can do, we can basically see how your brain responds inside an fMRI scanner when we show you drug-related cues compared to neutral cues. And if I put you inside the scanner and show, I mean, a substance user who is actually using drug, if you expose them to these drug cues, this is what you are going to see. So you will see that we have activations in different parts of the brain when we make a contrast between drug cues and neutral cues. So this is what we call cue-induced brain activation. So we have a specific activations in the brain when we expose people to drug-related cues. In a recent publication in JAMA Psychiatry, this has been published just a few days ago, they showed that basically drug cues and craving that is associated with drug cues is highly related to drug use and relapse. So we know that is an important part of basically addictive behavior. When we expose people to the drug cues, or when people are exposed to drug cues, they start to have a level of craving, and the craving could end up to drug use, which is something that we need to consider. And as you can see in their conclusion, they suggested to consider it as an important part of clinical practice when we are seeing patients with substance use disorder. But the idea of cue exposure and drug cues that would make people have drug craving is also related to how these cues are being presented in neural circuits inside the brain. And then the question would be, okay, if we know those brain circuits, is there any chance that we can use new technologies that we have for non-invasive brain stimulation to make an intervention on those brain circuits? So we have right now different technologies that they can non-invasively stimulate different parts of the brain. We have TES, TMS, deep TMS. So there are different technologies that people are using. I'm going to talk about these technologies and give you an idea about the current status of the evidence and what are the FDA approvals right now to use these technologies for addiction treatment, and what are the directions that we have right now to basically promote the field, and how potentially people among the audience could contribute to the scientific production that we are making in this field. the major question in terms of what are the targets that we need to target? What are the targets that we can basically stimulate and do the interventions with non-invasive brain stimulation technologies? This is a new paper that has been published like a few days ago, I don't know, 2 weeks ago, less than 2 weeks ago. And it has been published in Nature Medicine. It's a major journal in the field. So what they have done in this paper, basically, I'm not sure if you have been doing kind of neurological practice. When you have stroke patients, some of the stroke patients after their stroke, if they are a smoker, they just abruptly stop their smoking behavior. Or if they have been using alcohol, they abruptly start kind of to feel that they do not have any interest to alcohol consumption anymore. So it seems that when they got a stroke, some of the brain areas that are important for basically craving among those people are being affected by stroke, and they do not have any craving after the stroke. And the question was, is there a chance that we can kind of find the areas that are important for addiction that could be affected by stroke or other brain lesions? And then based on those brain lesions, defining what are the circuits that are important for targeting, to be targeted in neuromodulation. So that was the main question that they asked. As you can see here, it's kind of a really interesting group of colleagues and collaborators. I mean, Michael Fox in Harvard University, but you can see people, Khaled Mousavi, Shan Siddiqui, Amir Abdullahi, Harsha, and there are several colleagues from, and I know many of them, and they are from different parts of the world, including from India, Pakistan, Iran. So it's amazing to see the wide range of different people who are already working in this specific area of science. And there are definitely lots of potentials for others to contribute to the same question. And the idea is, okay, if you have patients that they have same symptoms, they stop using drugs, and they have brain lesions in different parts of the brain. If you make an overlap between these brain regions, at the end of the day, we will have some common neuroanatomical substrates that basically contributed to that specific symptom that all these patients are suffering from. So this is what they did. They tried to compare those who basically stopped smoking and those who basically continued to smoke. And what they realized that they cannot find any overlap between all those patients, something like 60 patients in one database, something like 70 patients in the other database. They haven't been able to find any specific sort of overlap, anatomical overlap, which was a little bit disappointing to some extent for those people. And then they have started to think about, okay, if we have patients that they have kind of activations or contribution of different parts of the brain, or they have lesions in different parts of the brain that are contributing to the same symptom, there might be an idea that these areas that they do not have any overlap, they might be a part of a same network. Instead of having overlap together, they might be part of the same network. And if we put them in the kind of a network level understanding about the brain, we can realize that they do not have any overlap, but they are contributing to the same network. And the reason that they have same symptoms when we have lesion in those three kind of areas is because we are basically affecting the same network. So we need to think about these issues in a network level, not in the regional level. And they considered that in their analysis. So instead of just considering those areas, they made a network level analysis to see how they can make that happen. And yes, they found the areas. So they found that there are specific areas that they contribute to craving behavior and drug use behavior, basically among all those people that are being discovered by network level analysis. They collected another database. So they have the nicotine basically addiction remission map, and they use it for another group of people who had alcohol use behavior, and they had a stroke and they changed their alcohol use behavior. And they showed that they can use the same map, and the most important factor that would contribute to the map would be the level of alcohol use among the replication database. So in the second database, they found that they can basically replicate the same results among alcohol users. And the map that they found among alcohol users would be really close to what they have in alcohol, which is quite interesting to see. Those maps are similar between alcohol users and nicotine users. And then the other finding that they had, one of the technologies that right now we use for brain stimulation in people with drug addiction is what we call deep TMS. And we have different coils for deep TMS. And there are positive findings with coil number H4, which is basically targeting the frontal part of the brain, and then coil H7, which is kind of stimulating mainly in the kind of the cingulate area and the kind of the more posterior part of the brain. And what they found, basically, this is the map that they had in terms of, it seems that the frontopolar area is an important part of the brain for being stimulated for addiction. So this is what they found in lesion studies. But as you can see here, these kind of maps that they found in lesion studies is being covered by smoking and alcoholism studies that people try to find treatment for using basically brain stimulation technologies, which is really promising, which is really exciting and promising. And I should tell you that smoking studies based on, I mean, these maps that have been done before realizing that these lesions are also having the same sort of map, based on these studies, they have been successful in receiving FDA approval. The first FDA approval for using neuromodulation in addiction treatment, specifically for nicotine use disorder. And this is the study that they have done. This is the kind of the deep TMS machine that is being marketed in the US, and I think you can imagine it's been being marketed across the world as well. This is the study that they have done. They have done 3 weeks of daily brain stimulation and then 2 weeks of just boosting sessions, 1 session per week. And what they have done, as you can see here, this provocation administration, it means that they have been exposing people to nicotine-related cues and kind of inducing craving among them before starting the session. So that is a part of the protocol. So they need to bring up the craving and then basically modulate those networks that are important in craving, which is an important part of the entire package of treatment. And what they showed a kind of significant reduction in terms of the number of kind of days that people have been smoking, and the kind of the significant effect, which is still at the level of what we have with varenicline and other basically approved medications for smoking, which is a little bit kind of, we still know that, I mean, there is an effect, but the size of the effect is not that large. So we need to think about, okay, how we might be able to make it more optimized and make a greater effect size. So it seems that there are lots of really interesting things happening, but we have some other kind of brain stimulation technologies that people are using in the field. And there are some new advances with what we call transcranial focused ultrasound stimulation, which is another area of brain stimulation with non-invasive brain stimulation. So one of the things that I use mainly in my lab is called transcranial electrical stimulation. And we can do that with direct current, with alternating current, with random noise. So this is what we are using right now. And this is how it looks like in my lab. We kind of target different brain networks and we stimulate different parts of the brain. The promise of electrical stimulation is, I mean, we can have really small devices, really inexpensive technology, something like $100, $200 for each device, which is really promising. If it can control drug craving, 4 a.m. in the morning, then you do not have access to anybody who can support you for controlling your craving, that would be a great breakthrough innovation in the field. So what we try to do, we usually kind of do this kind of stimulation. For example, this one is among methamphetamine users. We have published a few years ago, and we showed that if you put the electrodes on the kind of F3, F4, on the basically prefrontal cortical parts, we can reduce the level of craving that people have. So this is what we have shown before. But I mean, we have been talking about kind of prefrontal cortex, stimulating those areas and how that could be related to what we are showing here. The interesting thing is we have done a recent modeling study that when we put the electrodes on the dorsolateral prefrontal cortex or F3, F4, we are actually focusing electrical currents in the frontopolar area. So this is exactly the area that people in TMS studies and also lesion studies, they have shown that should be important to be targeted. So this is exactly the kind of the area that we are also targeting for stimulation, which is a really interesting, exciting thing to see how these pieces of evidence are converging to each other. And if I go back and show you the map that we published before for fMRI drug reactivity, one thing that would be interesting that this is basically the area of frontopolar cortex that we have been discussing about. As you can see here, we have certain activation and response to drug cues in this area. So this is an important area that we already have access, because in the frontal part of the brain is the kind of front part, and it's pretty easy to stimulate. And even if we do some connectivity between frontopolar area, we can see that this area is highly connected to amygdala. And we know that amygdala cortex is really important for basically processing drug-related cues. Previously, we published a paper that we showed that if we kind of evaluate the level of electricity in different parts of the brain, frontopolar cortex is the area that the level of electricity would be related to the response to the treatment, which is also another exciting evidence to support that kind of finding. But if we go, and this is another trial that we have done with 60 methamphetamine users. But as you can see here, people are quite different in terms of the level of responses that they have and the level of electricity they receive inside the brain. So there is a huge interpersonal differences, which we need to take into account. If I go back and talk about the first non-invasive brain stimulation approval from FDA, it goes back to FDA approval for depression in 2008. And because of that, people have been able to collect huge amount of data. And people basically targeted different parts of prefrontal cortex to be able to modulate depression. So this is what people are doing right now. But the response to brain stimulation, to dorsolateral brain, prefrontal brain stimulation, is quite different among people with depression. And people realize that there is something like 30% of people are responding, some of the people are not responding. And the question was how we can optimize the targeting. And I'm going to talk about this to see how we can use these evidences in addiction as well. So this is what we have in depression. But one of the really interesting findings that people have shown that basically, if we measure the connectivity of the areas that people are targeting for stimulation, people have been targeting different areas in the prefrontal cortex. And if we make a relationship between the level of clinical improvement and how these areas that are being stimulated are connected to an area that we call subgenual cingulate cortex, an area deep into the kind of anterior cingulate cortex, we call SGC, subgenual anterior cingulate cortex, subgenual cingulate cortex. So you can see the negative correlation, how these things are negatively connected to each other. The more negative connection would mean that they will have a better treatment response. So we need to find areas in the prefrontal cortex that are negatively connected to subgenual cingulate cortex. And those areas are the areas that they can basically make people to have a better outcome from the TMS for depression. Based on that, people have done a trial in Stanford. They call it the Stanford Neuromodulation Therapy. And this has been published just a few months ago in February. And they showed that if they target for each individual, so instead of just stimulating everybody in the same site, they go and do the stimulation in areas that are basically negatively connected to subgenual cingulate cortex in the individual level. And if they target those areas for 1 week and doing not only 1 session per day, but 10 sessions per day. So they basically compress the entire brain stimulation protocol in 1 week, in 5 days. And they showed that there is a significant decrease in the level of depression for those people. And without any stimulation, they had the same result for several weeks, which is really exciting. And the effect size is huge. Something like 80% of people are responding to that, which is amazing to see how individualized stimulation is helping people to have a better response to a stimulation. This is exactly what we are going to do for addiction, trying to basically do individualized stimulation for people. And this is what we have a webinar on July 27th. And if you are interested, we definitely will be happy to invite you to that webinar, which is free for registration. And we are definitely happy to have you as a part of that. So we are working on that basically new advances. Beyond those areas that we have been discussing in terms of medial prefrontal cortex and dorsolateral prefrontal cortex, there are some other networks, like the connection between prefrontal cortex and parietal cortex. We call it frontoparietal cortex. And we think that frontoparietal cortex is also a really important network because frontoparietal cortex is inhibiting the subcortical areas, the amygdala, ventral striatum, and then with this kind of network level stimulation, we can modulate subcortical areas. So this is another network that we try to modulate with some new technologies we call transcranial alternating current stimulation. And we try to optimize that in the individual level because people need to have different frequencies or different phases for the stimulation. And based on the frequency and phase of the stimulation, we can engage the network. And finding the target for each individual patient is not that much easy. So to be able to do that, we developed a setting to be able to do it inside the fMRI scanner. But before sending people inside the scanner, we had to test it with watermelon, just making sure that the system is working inside the scanner. As you can see here, we can just do a kind of recording from watermelon to see how we can do the stimulation or watermelon. As you can see, we can see the inside the watermelon as well when we do MRI. And of course, we eat watermelon after the stimulation session. That's a kind of fun part of the session. And after watermelon, of course, the PI, the main kind of project investigator, should go inside the scanner and test it on himself as well. So that was me going inside the scanner and receive the stimulation. And two brilliant postdoc and PhD students, Aki and Benny, they have been contributing to that. Aki is from Japan, Benny from Malaysia. So kind of a wide range of different colleagues that are contributing to that. We developed the protocol, some technical details. I'm not going to discuss all the technical details, but we published a protocol paper about that, and you can find the protocol paper. So, I mean, we provided all those technical details. And another kind of recent work that we showed how to optimize that in the individual level. So we are getting to a level to be able to do these stimulation in an individual level inside the scanner, even optimize that inside the scanner. And that is something that people are working on right now. But just to wrap up and conclude what we have been discussing about, we have recently done a systematic review of all the studies with non-invasive brain stimulation for addiction with Afra and Ghazaleh, who are working in my lab. And they basically found 104 studies with TMS, 67 studies with electrical stimulation, till end of April 2022. As you can see here, the number of these trials is increasing. These are the TMS trials, these are the TES trials, and the number is increasing over time, and people are working on that. And among those 171 studies, 125 of them are focused to craving, because craving is a really important outcome measure. But there are studies that are working on drug use, negative balance, trying to modulate those things. As you can see here, there are studies that they have several craving measures. So the number would end up with something like 160 compared to 125. But people are considering drug craving as an important target. People are targeting different parts of the brain, so they are looking for different targets that could be important. And the intervention is happening in different levels of recovery. For example, for nicotine users, there are studies that they basically start the stimulation before the actual treatment. So they just do it pre-treatment to just make people ready for the treatment. Or for things like alcohol, people might be during detoxification, or even might be during the recovery after detoxification. So people could receive non-invasive brain stimulation, different treatment status. And I really love this figure because it shows that how different countries are contributing to these trials that we have been discussing about. As you can imagine, kind of USA is the leading country, but we have people from China, Brazil, Iran, Italy, India, Germany, that are contributing to this basically pool of studies. And that was the reason that we made an international network of TMS trials for addiction medicine. And we have some webinars, regular meetings. We have a YouTube channel. We have a Telegram and also a Twitter channel that people who are interested, they can join us. Just last slides, as you can imagine, having MRI and brain stimulation, I mean, these are going to change the future of addiction medicine, psychiatry. Those who are interested to have more details, this is one of the papers that we have published discussing about all those technical details. If you are interested to know more about non-invasive brain stimulation, this is a basic paper for those who are interested to have a kind of basic introduction. We have a 2-volume textbook on neuroscience for addiction medicine discussing about all these technologies and new advancements. And it's also important to talk about these things with your patients in terms of how brain is involved in addiction. And this is the kind of series of posters that we develop, and we have them in different languages. We have them in Hindi. We have also have them, sorry, let me just go back to my slides. Okay. And we have them in Kannada, so we have them in different languages as well. Just last take-home notes. We discussed that non-invasive brain stimulation is important in the field. We discussed about cue-induced craving. We discussed about growing body of evidence. What are the targets for non-invasive brain stimulation? Large inter-individual variabilities, structural functional MRI to inform brain stimulation parameters. There are definitely potentials for international collaborations, and also it's important to educate patients what we are actually doing. And there are some collaborative consortiums that you can join. And that is my last slide. Thank you, my collaborators. And you can find my email if you want to send me an email and if there is anything that I can help you for. Thank you very much for your attention.
Thank you, Dr. Ikhtiyari. I think it was a very nice talk. I think it's important for the audience to sort of appreciate that the whole idea of non-invasive brain stimulation in addiction medicine is all about treating addiction as a brain disease and using, the different parts of the brain and the connections and how it is a kind of a bioelectric organ to sort of modulate the processes that kind of, are involved in the whole process of addiction. I think it was also important to sort of appreciate that Dr. Ikhtiyari was able to sort of cover in his talk, different modalities, the whole field of individualized neuromodulation, which is coming up over the past few years, which was, I mean, if you see the earlier studies, they were mostly about one-size-fits-all sort of modalities, but now it's more about individualized treatments. Because as we've seen across, the world and across different neuromodulation studies, it does seem that there is a huge amount of variability in the kind of results that we see, and individualization of treatment may be an important facet of where we may be going wrong, and also different phases of treatment. So I think it was a very good talk. There was a lot of area that was covered, and maybe a little complicated and too broad-based, but wonderful. I really enjoyed the talk. So I think there are some questions that we could take. So there is one question with regards to TDCS and neurofeedback. How effective do you think it is? So Dr. Ikhtiyari, would you please take this question?
Yep, I can see, I'm just kind of seeing the questions that we have in terms of how we might be able to integrate different levels of treatment. So I think it's really important for us to know how these different types of treatments are working if we want to combine them together. And this is how addiction neuroscience is moving forward in terms of giving us a sense of that, okay, how CBT is working, how contingency-based management is working, how all different psychosocial interventions that I'm sure Paul is going to talk about those things, how these sort of kind of psychosocial interventions are working, and how neuromodulation stuff are working, and how medications are working. And then the idea is, if we know how these kind of types of interventions are working and what are the targets that we are engaging, then we can use synergistic effects of those things together to boost up the treatment services that we are providing. And that is the promise of addiction neuroscience in terms of giving us a good understanding about how these different versions of treatment and these things are working together. So, I mean, even when I was talking about neuromodulation trial, you always see that there are some psychosocial components to those trials. So we are not just doing a stimulation, We are doing a stimulation in context of a psychosocial intervention, and then we provide people with medication. So it's a combination of everything together. And the question is how we can optimally kind of merge these things together. So we are not supposed to just say, okay, I'm a neuromodulation guy, I'm just gonna stimulate people without thinking about what are the things that are happening in the context of the stimulation. So it's gonna be important. And that is kind of the same issue with neurofeedback and brain stimulation. And I can see that there are people asking about low frequency RTMS or CTVS or cathodal TDS, because in neuromodulation, we can have stimulatory interventions and inhibitory stimulation. And low frequency TMS or CTVS or cathodal TDCS, there are inhibitory modulations. It seems that we are still not 100% sure in terms of whether, for example, cathodal stimulation is really inhibitory or it's going to be a stimulatory. But even in the map that Michael Fox and his team developed in Nature Medicine, you can see that they are suggesting some areas to be stimulated and some areas to be suppressed. And frontopolar area is one of the areas that they suggest to be basically stimulated, and some areas in dorsolateral prefrontal cortex or probably in the inferior frontal gyrus to be suppressed. So there are still discussions in terms of how these things are actually working. And I'm not 100% sure that even CTVS, so this is a discussion that I had with Colin Handel, who is mainly doing CTVS, in terms of whether it's just really doing the kind of the inhibitory part, or it also stimulates the brain. So there are still some discussions in terms of what should be done in terms of the stimulation or inhibition of those areas. But we know that when we put electricity on those areas, we can modulate the brain response to drug, which is really exciting. And it seems that that is going to be the future direction for making that happen. And I can see here that one of my colleagues basically shared some of the kind of the videos and papers. So you can find those things, and you can just Google and find those areas. So, and I will be definitely happy to help people. And I have been in touch with colleagues in All India Institute of Medicine, and I think they are doing an absolutely brilliant job. So I think that some of the kind of the most kind of brilliant people in the field are from India, and I'm hopeful that we will still have some other brilliant colleagues from India to basically push this area forward. Okay, so there's one more question. Do the neuroanatomical targets of stimulation and non-invasive brain stimulation vary across the substances being abused? That's a really good question. It seems that at least so far, we know that there is a significant level of consistency across different substances, which is promising. Even in Michael Fox paper in Nature Medicine, as I have mentioned, they showed that they can replicate the results that they develop in nicotine users in alcohol users. So it seems that there is significant consistency across different populations of substance use disorder. And this is what we are seeing also in our fMRI studies. I think the major differences that we have is among the individuals. So within nicotine users, we have a significant variation. Within alcohol users, we have and we need to consider those within population variations in the treatment. And I think that anybody who has done kind of clinical practice in addiction medicine, we know that people are really different. And this is how we try to address these individual differences in our treatment, whether it's a psychosocial treatment, whether it's kind of neuromodulation, or even in pharmacological interventions. Okay, so I guess there are no more questions. So I think, Naresh, we can stop this session here. Thank you, Dr. Hamid. It was very nice, and I personally enjoyed the talk very much. And hopefully we can sort of get in touch later. I'm sure anybody with any pending or any lingering doubts can get in touch with him, and I'm sure you'll be glad to respond to them. Thank you very much.